This week on the BackTable podcast.
But the vast majority of kind of private practice IR guys are being, kind of looked down upon by their diagnostic partners. So now you take that business outside of the hospital and then you start printing money basically for the group and say, look, I'm now bringing in seriously positive revenue for you. Give me my time. Let me build my clinic. Let me build my business. And it will continue to pay in procedures and downstream revenue. You've now added a really seriously important arm to the diagnostic radiology group that they before was more of a loss leader. IR is something they needed as a service commitment. We have to do your abscess drainage, we have to do your PICC lines. That's fine, but we want to read your brain MRIs. Now it's the other way around. Now IR is driving things, and IR is sending checks to the group and saying, just let us do our thing, and we're going to keep building, and you're going to see we're going to keep making this better and better. And I think that's the future of IR.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or BackTable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email us to let us know how we can make this a more valuable resource for the endovascular community.
Simple innovations to the venous seal closure system plus new techniques mean greater impact for you and your practice. Experience greater efficiencies, greater control, and greater ease of use with the enhanced venous seal closure system. Learn more by visiting medtronic.com/impact.
Market declines, unemployment, the COVID-19 pandemic. Don't let headlines derail your long-term financial strategy. This BackTable episode is brought to you by Yafi Tadessa, Edward Jones financial advisor in Dallas, Texas. He'll work for you to help you understand the impact of short-term events and how to prepare for the long term. Learn how he can help you reach your financial goals. Visit edwardjones.com/Yafi Tadessa, or a little bit easier to remember is backtable.com/401k for more information. Edward Jones, member SIPC. Mike, do you have a financial advisor?
Nope.
Why not?
I don't know, man. I've been trying my best to do it on my own. But no, it's an important question. I started my current job and they didn't have a 401k that started for my first year. It was like, so I wanted to meet my contributions for that year and I didn't know how. So I didn't.
Yeah. How long do you think you're going to do it on your own for?
I don't know. I just had my third kid, Aaron. And
well, there you go.
All this free time that I thought I had, which is already very slim, is gone. So I am reaching the point where I want to make sure that I'm checking all my boxes and that I'm not getting behind on any of this stuff.
Yeah. Well, if you want to, I would tune in to this webinar that Yafi is going to do on retirement plans and tax savings. And the easiest way to sign up for it is to go to backtable.com/401k. The information will be on the website or on that page. So go ahead and sign up.
Okay, I'll do it.
All right.
This is Michael Barraza, your host for today's episode, recording in Baton Rouge, Louisiana. I'm honored to welcome my friend and peripheral arterial disease extraordinaire, Mike Watts, recording from Oakland or Las Vegas or wherever it is the Raiders are hailing from right now. I see her. What is that right behind you?
I got two things in this office. Otherwise, the office is completely empty. I have the diagram of Marcus Allen's run from the 1983 Super Bowl, and then I have the replica brick that sits in the Raiders' new stadium in Las Vegas with my kid's name is on it. That's all I got.
As Mike knows, I would be happy to talk about the NFL for an entire podcast, but instead we're going to talk about OBLs, outpatient-based labs, and what you can do with them. And, when most people think OBLs, I think PAD, and I think about my dentist. My dentist technically has an OBL and he doesn't do any PAD. And
minimal at best.
Yeah, certainly not on purpose. And so, one of the things we wanted to do is talk to you about, what else can you do in an OBL and what does the horizons look like for really, all kinds of outpatient labs that we have in our specialty. And so, one thing I wanted to have you do first is, give us a little overview for people who aren't aware of this, especially the trainees. Like, what is an OBL and what's the difference between that and ASC?
Yeah, sure. So when you're talking about physician practices outside of the hospital, any office, I guess, where a physician delivers a certain amount of care, diagnosis, patient visit is a office-based lab, basically, a lab if you do anything. But I guess technically it's a point of service 11, which is just kind of insurance billing jargon for, a place where a physician does their work outside of the hospital. This is opposed to an ASC, which they dub the point of service 24, which is more or less any place where a physician does any therapeutic work other than their office. So what's this mean, really? OBLs are kind of, they're overseen, depending on the state, by the National Board of Medical Examiners or sometimes the state, but they're very loosely regulated. And they are reimbursed for what you do there significantly different than in the hospital or an ASC, because it's basically just a physician, wherever they are, doing whatever it is they do, being paid for their services. An ASC is a much more strict definition, and you have to meet a lot of different criteria as far as like space, hallway width and dimensions, HVAC systems. And once you kind of meet all these criteria, you're then licensed by the state. And that allows for different things. One of the main reasons I think people do ASCs rather than OBLs is an OBL can be owned by physicians who practice within that state. An ASC can be owned by corporate entities, non-physicians. They can have shares, fractional ownership. And so it can be more of a hospital venture or a corporate venture, or a multi-specialty physician kind of venture for business reasons. And there are also reimbursement pluses and minuses for each one. So OBL, basically just open up a spot, you practice there. It's very little oversight. State by state, everything I say is different. I think Florida, if I'm not mistaken, there is some licensing or state inspection that needs to be done, but other states it's pretty much very minimal. And ASCs are strict and have kind of other consequences with them if you choose to go that route.
Right on. So I know the answer to this, but just again for our guest, I mean, why would somebody in a hospital-based group want to open an OBL? Like, what are some of the advantages of it?
Yeah, there's quite a few. So I think the first thing that everyone sees is reimbursement. And all of this stuff is public. Medicare reimbursement rates are public everywhere. So what Mike said when we started was, everybody thinks PAD. Well, why do we think PAD? Just from a physician standpoint, if you're to take 37227, which is the SFA atherectomy and stent code, so it's just the biggest one, and so it makes the biggest kind of impact when you look at it. If a physician were to do that procedure in the hospital, they'd be reimbursed somewhere about $1,000. If they do it outside of the hospital in their office, it's upwards of $20,000. It's taken a hit recently, so it might be like $18,000. So you're looking at 18x in reimbursement. And now all of a sudden, when you take that and you take the implications of that, what that means is, all right, if I do a couple of these a week, basically, I'm bringing in more money than I would if I were in the hospital. So now I can pay rent somewhere. I can hire my own staff. You guys have all been in hospitals long enough to know that, there's the tech who, when they got to scrub the case, they're rolling their eyes, you're rolling their eyes. There's the nurse who doesn't agree with anything you say. And, you can avoid that. You can have your own staff. You can have a place where you want it. You can have the patients walk in. One example that I mentioned here for patient access, we can do a thyroid biopsy in the hospital, or we can do a thyroid biopsy in the OBL. Thyroid biopsy in the OBL, they check in up front. The second they check in, someone walks them back. Nurse brings them into the room, explains the procedure. They hand me the consent. I have them sign it. I sign it. I give them my little spiel while I'm ultrasounding, do the surgical timeout, I numb them up, take the samples, put a Band-Aid on, send them on their way. They literally spend 30 minutes in the place.
As opposed to the 3 hours they spend when they come to my hospital.
That's exactly it. They go to the hospital, they go to registration, they got to check in. There's a process involved with that before they actually get to radiology. And then they're being asked questions as if they were going to have, basically a laparotomy. Literally every nursing question is the same, from not just medical history, but, the are you safe at home? Do you feel down, depressed, or blue? Do you have any abnormal antibodies in your blood? Like, there's these questions that, somewhere tripped somebody up years ago and they just get added on. So you've all seen it in your hospitals, but it just, you can slim down some of that in the outpatient lab. So you have a much more kind of convenient place for the patients. They prefer it. There's no parking generally. I mean, I've been involved in some pretty big medical centers, and the Press-Ganey scores would be drilled into us. Where's our biggest source for improvement? What's our biggest detriment? Parking. Yeah, I was at the Cleveland Clinic, right? I mean, the mecca of all medicine. The people who come could get anything cured or fixed like they could get nowhere else, and they didn't want to come because of parking. So you kind of take that, out of the equation. Plus scheduling. I mean, all right, so I want to work from 7 a.m. to 3 p.m. Sure. I want to work from 9 a.m. to 9 p.m. Sure. You're kind of in control of how you want to run that, how many days a week you want to run it, and what you want to do. The hospital practice, one of the last, when I was doing full-time hospital practice, one of the real things that kind of drove me away and realized I wanted to make a switch was, I had little kids at the time. There's something I wanted to do. And, I was on call Friday, which is great. If I get called, that's fine. But when I get called at 4:30 and say a patient needs a dialysis catheter exchange, but a patient's transport doesn't get down, the nurse's shift changed, transport shift changed. Oh, hold on, they want to put a central line in. Oh, whatever. So now it's 7:30 by the time the patient gets down. I miss whatever it is my kids were doing.
Right.
It doesn't. There's a lot to be said for having an outpatient practice, and it's certainly doable with the way the reimbursements work.
Yeah, and it sounds like in addition to a lot of advantages for you, there are really also a lot of advantages for the patient. If given the choice, I would guess that a lot of them would choose the outpatient experience. I mean, for far more than just parking.
Yeah, well, the ones who have both experiences, no doubt about it. They, once I've treated them in my lab, they absolutely will not go back to the hospital unless they absolutely have to, and then they'll try their best not to. But the biggest, which no one thought about 2 years ago, let alone 5 years or 10 years ago, from March of 2020 till now, there's a bit of a pandemic going on, and nobody wants to go to the hospital. Nobody wants to see other people.
I live in the South. We don't have one here.
I know. Texas, I hear, definitely doesn't have one. But up here, people don't want to go into public places where sick people might be. So
it's a great point.
So there were so many things that were not being done in the hospital that we really never missed a beat because patients felt safe with us.
Man.
They felt, there was very few people in there at a time. We could space things out. We could show them how safe everything was, and they felt secure coming to our small place just to see us and then be on their way. So that made a huge difference. I talked to a bunch of people, kind of on consulting basis about, what's the market like? What's it like outpatient? What's it like hospital? And then these hospitals were shutting down all of their elective surgeries. And, we did that too for a while out of necessity early on, just because, when masks were short, everybody kind of had that moratorium. But as soon as we were allowed to do things, the volume just blew up. Over 100%.
I never thought about that.
Yeah, it was a great, safe place for patients to go. And I think that's going to prove to be the case from here on out.
Yeah, it makes perfect sense. So, I know a bit about your own practice, but tell us a little bit about the history of your own outpatient lab in your practice. You guys have built something pretty impressive.
Yeah, so this is my second experience with the practice in outpatient lab. And I want to talk about this one specifically because the way it kind of originated is my partner, Nick Petruzzi, who is, he's fantastic. He's a fantastic doctor. He's a fantastic person. And he's really a fantastic businessman. He joined this practice kind of on the near Atlantic City on the Jersey Shore in 2014, I think. And, what he basically did is said, hey, look, we're a couple IRs covering a hospital practice, but we have a lot of outpatient imaging centers. The reimbursements really are such that if we can do some of the basically PAD work and stuff that we're doing in the hospital, if we can do it on the outpatient side, it's going to be very advantageous to us. And some of the older guys in the group said, well, look, you can bill whatever you want, but I don't expect to get paid. And he's smart enough and persistent enough that he called some of the C-arm distributors and said, hey, can I borrow this for a week? Can I trial it? He got a little room back behind one of the MRIs in one of the outpatient imaging centers. Rounded up a couple patients, treated them, submitted them, got it paid, went back to the board and said, here you are, guys. Here's what we make for doing these things. And pretty much got the okay to say, all right, well, you've basically proven your point. How many days are you going to need to start? How many nurses are you going to need? How are we going to do this? And then he basically built it from the ground up. So that started 2014, 15. They opened up a second center in another county, 2017, 16, 17. And now we just opened up the third that I'm intimately associated with this past November.
Yeah.
So now it's basically, say, 6 IRs. We've now included 2 vascular surgeons, 3 completely freestanding OBLs, and then 2 hospital, a hospital contract associated with 2 hospitals. So that's kind of how it built and how it is. And the reason I'm so kind of high on this model is that, we all kind of spend 80% of our time, most of us spend 80% of our time outpatient and 20% of the time inpatient.
God, it's awesome.
Yeah, it really is. Because, what I now do and what we all kind of do is we use our hospital day as basically an overflow for our bigger OBL procedures. So now when I go to the hospital, like I'll be there, next week, I'm booked with cryoablations. I have a day full of cryoablations, right? So I'll be doing, we can get into all the other procedures we do in the OBL, but I'll be doing a lot of critical limb ischemia, and I'll be doing some UAEs and kyphoplasties and, a bunch of other smaller things. But, the referrers and the relationships that we've built know that I'm going to do ablations. I'm going to do more IO stuff. I'm going to do really kind of crazy, complex venous reconstructions because I have that hospital ability to do it.
Man, I'm honest. That sounds awesome. I'm actually really excited for the site that you guys are going to open for me in a couple of years. But no, it speaks really favorably to the rest of your group that, they entertained Nick's idea and like, let's just do this. Let's try it. And, when it worked, they ran with it. I think that there aren't a ton of places, not a lot of groups where that happens.
No doubt about it.
Certainly not as smoothly.
No doubt about it. And there's, there's not a lot of people like Nick who have that, kind of intelligence and drive.
No, I've gathered that.
And can really, and is that convincing because you just have so much faith in them. And it's paid off, massively. The funny thing, but these other guys don't know is, Nick Petruzzi was my fellow when I was at Penn. I was at that point, I was associate fellowship director and he was a fellow. And then he went off to this practice. And then, 4 or 5 years later, he's calling me and like, hey, we're going to open this extra center, this third center. We need you to start it from the ground up and just hit the ground running.
Right.
So
and you're good at that.
So right. So never piss off your fellows too much. They may be your boss.
No, I'll remember that. Okay. Well, you bring up another good point is, which are the cases that, you're seeing either in the lab or in the hospital and you decide to, this is a better case for the hospital.
Yeah. That's
vascular or otherwise.
Yeah, no, absolutely. So it's really, it's a great, again, I'm going to keep kind of banging this drum, but it's a great situation to have because what happens is the referrers can refer anything to us. All right. So, and there's a couple of reasons for that because we're never going to say, well, we can't do that because it involves thrombolysis. Well, we can't do that because, we need a vascular surgeon involved for a common femoral endarterectomy because guess what? Our group includes 2 vascular surgeons.
Yeah.
So what we tend to do, and so kind of one of the bigger groups, if I talk about this one outpatient center, this one office interventional suite, OBL, whatever you call it, that I just opened in November, one of the relationships that grew very, very quickly is with the oncology group.
Really?
So I do their ports, I do their port removals, I do their biopsies, I do their tunneled peritoneal catheters, their Plerex catheters. I do everything for them. So I want them to know that I'm full service IR. So they will say, hey, I have, this tumor for an ablation. And they don't know what I do in the office and what I do in the hospital because
They
I
don't care.
I don't want them to know. That's right.
Yeah.
They don't care. So I'll do tumor ablations for them. They'll ask me weird things like, oh, hey, this woman had, a tumor that disappeared after chemo. Now it's back. Can you put a fiducial marker in it just so we know where it is? Sure. I don't care. But it's something I want to do in the hospital. So I'll do the ablations in the hospital. They asked me to do a primary feeding tube, a G tube. Sure. I could do it in the office, but why? I mean, it's a risky thing. 90% of them go right, but if they don't, they don't. So I can do it in the hospital. I mentioned cryoablations. So same thing, there's a urology group that wants me to do pretty much everything. So I do stone access. I do primary nephrostomies. I do double J's. I'll exchange double J's. I'll do all of that. But when they say, hey, this guy's got an RCC, I'm like, great, send him over. And then I treat him in the hospital.
Yeah.
As far as I mentioned, like the complex filter retrievals, venous reconstructions, all things we don't do in the hospital.
Yeah.
But when it comes to, PAD and CLI, basically the entire practice is pretty much CLI. We work with the wound care centers. Petruzzi is wound care certified and spends a half a day at a wound care center. I'm about to be wound care certified. So that's where we get the vast majority of our referrals from. But, we also are data hounds. I mean, so,
Right.
I still, write papers and review articles. Petruzzi still does. We're involved in studies. So when someone has, like say a last guy that I did in the hospital had like bare metal stent, full metal jacket, 35 centimeters occluded. Well, I mean, the best thing for this guy is Vibons. Right. They're using stent grafts to line this gives them the best chance. Well, that's about $35,000 worth of stent grafts.
Right.
So we bring them to the hospital, and financially it works better. I don't have to say, no, I can't do this patient. I can get them evaluated for bypass. Surgeon says, hey, just try this and see what happens. You can do things that make financial sense at the hospital there. And then, things with general anesthesia and things like that. That's one thing I didn't get into with the ASC versus OBL. There's some, depending on the state, and I didn't want to get into it because it's really sticky, what kind of sedation you can give. ASCs tend to allow for certain types of deep sedation anesthesia. Some OBLs will allow moderate sedation. Some will only allow kind of oral sedation. Really depends on, where you are, what the local rules are. But as far as general anesthesia, we have the hospital for that. So some of the bigger, I have a partner, Chris Kim. He's wonderful. He does a lot of PAEs, and he's done the vast majority of them at the hospital, but he's done a few in the lab, and they've turned out well. And what that has actually kind of led to is the next iteration of our original site. Now that we've outgrown it, we'll have a fixed unit. We've already bought the fixed unit.
Nice.
We bought the fixed Philips Azurion, fancy whatever for our outpatient lab. And so, he can now do his prostates there. That lab will have a hot lab, so we can do our Y90s there. We can do our oncology there.
Yes.
So
you're going to do the Y90s there.
Correct.
That is exciting. So how is that going to work when you do a mapping?
So that's a fantastic question. See, it's actually, it's relatively easy for us because we're pretty much across the street from the hospital in that center. I know that's always the biggest issue, but we are basically going to say, all right, here you are, go, we're going to have to bring you across the street.
Across the street, take a picture. Yeah.
That's pretty much it. Yeah. But the companies, the vendors have all the rest of it, pretty much, just plug and play, lock and key kind of thing. As long as you have the facilities to do it. And we didn't want to do it, unless we had the right imaging, so we could do our cone beams and we could do everything the right way. And as long as you have the willingness to make that investment and the patients to do it, it'll pay off, just fine.
So what are some of the other, less common or less ordinary things that you guys are doing in your labs?
Sure. I don't know a lot of people who are doing like full kind of urology stuff. I think a lot of people are doing ports, PICs, biopsies, all dialysis stuff. We just did our first endo AVF in the lab.
Nice.
We've done some in the hospital, and we have a lot of patients again because we're kind of we have our surgeons as part of the group. We have a lot of patients we've done in the hospital.
Sure.
But the problem with the endo AVF is, we use the Ellipsis product, which just got bought by Medtronic. Ellipsis fought very hard to get a code to get it paid, and it gets paid in the hospital, but I think they struggled to get an outpatient code. They finally did as of July of this past year, but there was no Medicare, basically coverage determination. There was no guidance as to what it should pay. So it was left up to the regional Medicare carriers. And most of them just never assigned it a value. So now, I think now that Medtronic is kind of involved and have their multi-billion-dollar company behind it, they do have a valuation for the code. So now it is something that can be done outpatient. And the other part about that is once you have a code where you have a value, then there's some negotiating room you have with the company as far as what are we going to pay for the product.
Okay.
Which, just to segue into another situation, the OBL pricing for most medical devices is significantly different than hospital pricing. That there's some black box there, and I'm probably not supposed to get too much into it, but it's a widely known secret that if you're paying $3,000 for a device at a hospital, the OBL price may be $1,100 for some of this stuff. So that's another reason why a lot of this stuff is more beneficial in the outpatient setting. Because if you do the math and if you were to say, all right, well, this is what my reimbursement is, for an outpatient procedure, and you use hospital pricing, it doesn't work quite as well. But the companies know that the volume is going to come from the outpatient labs.
Absolutely.
You try to do 6 big procedures in a hospital, in an OR and an IR suite, with the turnover time and the patient access issues, it's going to be a major problem. But it's not uncommon at all to do that number in an outpatient, office. And so the volume gets driven through there, and they make their money on that.
Right. I mean, that's certainly important for everybody to know, especially if they're considering opening one of these. You're not paying hospital prices for these, not necessarily, at least. And certainly you shouldn't go into it expecting to. So I ask you just anything else you're thinking about maybe adding in the future, anything funky you've heard anybody else is doing, and basically just, what the horizon looks like for OBLs. And then if you think it would be useful or even relevant to just see if, how the relationship has been with the hospital once you guys decided to make that move.
Sure. So I am convinced that this is the future of IR. I mean, really, it really is. And the reason I think it is if you look at kind of the general private practice radiology group, what you hear when you're a fellow coming out into the world about private practice is the big concern is, look, you're not as valuable as a guy who's reading brain MRIs all day. If you take an hour to do a lung biopsy and you spend, 15 minutes consenting them and 15 minutes doing orders afterwards, and then, you got to monitor them, and then, you're going to go see a consult for a uterine artery embolization that may or may not, decide to do the procedure. Now, basically, you're so far behind someone who's read 50 brain MRIs in that time, you're not valuable. And then you say, well, give me a PA or an NP, give me some clinic time. Also, now to the group, you're even less valuable. So, what IR becomes is you do what's asked of you when it's asked of you, and you do, you read a stack of films in between. Now, there's certainly a lot of different models, and you've interviewed, a lot of these really kind of badass IR guys who, are doing, a handful of Y90s every day, or they're doing a bunch of PAEs, or they're doing, everything. They're doing fine, but the vast majority of kind of private practice IR guys are being, kind of looked down upon by their diagnostic partners. So now you take that business outside of the hospital, and then you start printing money basically for the group and say, look, I am now bringing in seriously positive revenue for you. Now I need an NP. Now I need, just give me my time. Let me build my clinic. Let me build my business. And it will continue to pay in procedures and downstream revenue, you've now added a really seriously important arm to the diagnostic radiology group that they before was more of a loss leader. IR is something they needed as a service commitment. We have to do your abscess drainages, we have to do your PICC lines, that's fine, but we want to read your brain MRIs. Now it's the other way around. Now IR is driving things, and IR is sending checks to the group and saying, just let us do our thing, and we're going to keep building, and you're going to see we're going to keep making this better and better. And I think that's the future of IR. That's great for the groups. The hospital, how that is received by the hospitals depends whether or not you're working with the hospitals.
Yeah.
So our first group, our first OBL, we are the IR group at the hospital.
Okay.
The one that I'm starting now, we are not the IR group at the hospital. That's 2/3 of a mile down the road.
Okay.
So that's why that's been extremely beneficial to me, because I can offer them services, oncology services, CLI services, urology services, UAEs, things that their group are not doing. So now that's where it's so important to me to be a full service IR person for these groups, because they're so unhappy with the IR group that they're dealing with, which, is a very, very basic bread and butter kind of IR group. They haven't done anything new in a long time. And, they're just kind of, I don't want to say spoiled. I don't know the guys very well, but when the urologist says, hey, I want you to have a lower pole access, I want it here, I want it there, and then they, and then I want an NU down, they're like, well, you'll get a mid to upper pole access with a nephrostomy, and it's going to be, 8 French, and it's not going to be what you want. It's not going to be in the right place, but hey, I got it in.
Right.
So that has been, I think, beneficial. The hospital, we there's a lot of gamesmanship between us and the hospital, but it's all pretty positive. They put some ultimatums on their referrers. Hey, don't send to this guy, and they're like, well, we have to, because he does what we need them to do and you guys don't.
Right.
Which, we'll see where it goes. We've only been doing it for 5 months, but there will definitely be, we'll definitely come together on some things, and it's probably going to be beneficial for us, in the long run. And then the other model is where we are the IR group. They know that we're going to bring a lot of patients there. They know we're providing services. They're happy they're not partner with us
Right.
in any real way, but they know, how we do things. We work well with them. We refer a lot of patients to them. They refer a lot of patients to us. And so it's very nice. It's a nice relationship with them. They're employed vascular surgeons, and that's a little bit more, there's a little bit more BS that kind of goes on behind the scenes there.
Sure.
As far as referral patterns and stuff, but they're happy with the way we do things.
Well, they have to be. If you're doing the best work you can, you're doing the best work for the patient, and,
Right.
and you're the best available, there's going to be business for you.
Right. It's a great way to put it. That's probably the motto, most everybody should be living by.
Absolutely. So what else am I missing, Mike? I mean, what's on the horizon for OBLs? I agree. I mean, I think that, that the horizons are very bright for OBLs in general, but, really anybody who goes out and does work like this.
Yeah. Well, I think that, EMBOs are going to be the next big thing in OBLs.
Okay.
So we're doing geniculars for hemarthrosis, but we're not doing them for osteo, but I'm sure we will be.
Right. I think
everybody's
that's
waiting.
coming.
Everybody's waiting for bariatric coming down the line. PAE, you can fill, your whole week with PAEs. So that's, and UAEs, of course, that model's been proven dozens of times. So I think EMBO, because, CLI, these patients tend to be pretty sick. It takes,
Sure.
It takes a lot of expertise, and you really have to live and breathe it to do it well. And, I think we've seen for 10 years now, some of those codes being abused, and the numbers being knocked back and back as far as reimbursement. I'll never give up doing it because I love doing it, but there definitely will be people who are like, well, it's not worth it anymore. What's the next big thing? And those cardiologists are going to have some coronary stuff and some EP stuff that they can probably do as their next code. We'll have EMBO, who knows, vascular surgery, I'm sure we'll have something else that they can do. But, as that code kind of fades away over the next couple of years, or those codes, there will be other ones. I think EMBO probably is the next the next big one, which I think will be accessible to most people. There's keep an eye on PERC AVF. Could be a really big change in the way patients are treated.
Yeah.
Depending on how these things kind of pan out. The data looks pretty good early on. And then, there's stuff that we don't do, pain management. People have been doing that stuff forever. That's something that we've never gotten into, but definitely can be done. And who knows what's going to happen next, but it really does depend on where you kind of settle down and what the market is, and just being open to anything. Veins,
Right.
That's another huge practice that I'm involved in, but I don't even, it just happens. If
Right.
they see vascular something, you're going to have more self-referrals and referrals from people you've never heard of than you can handle. But it really does come down to knowing your referrers and proving to your referrers that you're the best person for the job. And it's really easy when you have a model like this where you've chosen the front desk people, the nurses, the techs, the MAs, and when that patient comes in, they're treated like family. It's just so great to see you. How are you? Let me walk you back. Oh, let's talk about this. Let's talk about that. We're laughing, we're joking, we're talking about whatever. The doctor's right there. Hey, how's everything? We're good. We're great. Nice to see you. Everybody's happy. Everybody's pleasant. They leave and they're like, I can't wait to go back. And then they go back to the referrers and they say, this place is wonderful. And look at my foot. Remember all those black toes I had? They kind of sloughed off and now I have pink stuff under there. This is unbelievable. And then you get that experience once for a referrer and they're with you forever. So, it's easy to do it in this setting.
Well, hats off to you for what you and Nick and the rest of your crew have built. And thank you for taking the time to join us and share your expertise.
Yeah, it's absolutely my pleasure. I've given this talk a couple times to medical students, and I actually keep an eye out for an SIR session, which is basically the same thing. That's coming up this year, but it's just there's a lot of benefits to doing this, and I'm sure for a lot of reasons that this really is the future. It allows IRs to be the clinical doctors that they want to be. And have their clinical practice, and I spend more than half my time seeing patients in the office. And I love it. And, it's really important for the patients to know you and to know that you're the person behind the mask when you're doing the revascularization or whatever you're doing. So, it's just one of the reasons, there's no escaping kind of the OBL trend.
Awesome, man. Thanks again.
You got it.